Dr. Abdalla Alasiri, who will be talking about very interesting topic, AI and machine learning for early detection and treatment optimization of COPD patient at risk of exacerbation. Please welcome Dr. Abdalla Alasiri.
Thank you, Dr. Hajar, using me, and fortunately that I present before Prof. Hamdan, and I feel difficult to present after a pioneer consultant in COPD, Prof. Hamdan. So my talk will be about the artificial intelligence and machine learning for early detection and treatment optimization of a COPD at a risk of exacerbation. So let us learning from other chronic disease like a diabetes. And in the United States, they have 30 million American currently, they have diabetes. And 86 millions of those patients, they will be a pre-diabetic. And 1 in 3 Americans they born today will develop their diabetes in their lifetime. And we know that there is a high risk of chronic developing a complication like a heart disease and cardiovascular events. And the average of medical costs for a person with diabetes is 13,700 to and around 8,000 of is directly spent on the treatment. So they do the early intervention. They are interfering the program initiated to prevent consequences or delay the prognosis, improve the outcomes, and reduce the economic burden. And they try to identify those patients who are at high risk for diabetes, for example, those who have a fasting blood sugar above 100 or BMI above 30, and they interfere by changing the lifestyle for these patients, and they try to achieve a healthy lifestyle for identified risk patients. So the participants in the program reduced their risk for developing diabetes by 58%. Also, the other experience from the cardiovascular, according to the American Heart Association policy, they said that the process of atherosclerosis might start early in the youth and continue for a decades, but will lead a complication, fatal or non-fatal cardiovascular events like MI or stroke. And the direct costs for those patients is higher and might will reach by 2030 to 1 trillion. So the early intervention for those kinds of patients by their policy that suggests the public policy, community efforts, and pharmacological interventions are all likely to be cost effective and often cost saving comparing to the common benchmark. So the prevention of the cardiovascular disease will also provide a great value in developing a and healthier and more productive society. Okay. The impact of COPD productivity losses and direct medical costs in Saudi. This is according to the World Bank statements and their advisory according to the health care facilities and authority. They conclude that the productivity losses due to the COPD is almost $6.5 billion in 2019. This is the indirect cost is fivefold the direct cost, which is around 1.3 billion per year for a COPD patients, comparing to the five national chronic disease, which is the first one is the diabetes. So we are facing a very complicated problem costing around a very heavy burden on the Saudi Arabia response to a 20% of the total burden of the major national chronic diseases. And as we know, the COPD exacerbation is leading to increase the cardiovascular events by the double in the first 10 days, either the myocardial infarction or stroke. And with each acute exacerbation, we have another acute exacerbations, and the delay of maximizing the treatment might will lead to more exacerbation and increase by 79% in the severe exacerbation and 68% increase odds of moderate to severe exacerbation. So we have to interfere as soon as possible to delay these, to decrease the exacerbation and the complication from the exacerbation. And when we compared the mortality rate in a patients with MI, either they have a primary perfusion or no perfusion, with a COPD exacerbation, we find that the mortality rate with MI is much better than those with a COPD exacerbation. So according to the goal 2024, the mortality is reduction before was by oxygen therapy, smoking cessation, lung volume reduction surgery. But in 2024, they are recommending a triple fixing dose combination as a potential option to reduce a mortality in COPD patients with a history of exacerbation. And according also to the newsletter of a COPD group, they are talking about the first the first newsletters in May 2022. They talk about the inhaled triple therapy with 2 doses of glucocorticoid does to moderate to very severe COPD. And the conclude of this study was the triple therapy show a reduction in the acute exacerbation. Also, the second newsletter by COPD group, and they talk about the COPD mortality burden and COPD cardiopulmonary interplay, and the background that the mortality of a patients with COPD suffer from the comorbid cardiovascular disease, accumulating evidence temporally associated between a COPD exacerbation and acute cardiovascular events. Also, the mortality, the third newsletters show that the triple fixed dose combination that's reducing the exacerbation by 49%. So if we are enter to the artificial intelligence by predicting the diagnosis of COPD, and after the artificial intelligence predict those who are at high risk for a COPD, they start to detect those patients and diagnose them as a COPD. And then after we diagnose a COPD patients, we will go for a prognosis. And the COPD risk factors, we can download it on the artificial intelligence, and we identify those patients as those who have a history of 1 or more moderate to severe exacerbation, history of 1 or more hospitalization or emergency visits, those patients who have a blood eosinophil more than 100, and those who have a higher number of dispensed SABA, rescuer more than 6 canisters per year, and history of concomitant asthma or cardiovascular events. So after we prognose the patients, the machine learning will come, and they divide the patient to 80 and 20%. 80% they will be followed by the machine, and they are using the model to learn the pattern and dynamics need to predict the outcomes. And 20% the machine will not follow, and to examine the specificity and sensitivity of this model. And the model will, the machine learning will follow the patients regarding the performance of prognosis system across all 4 complications. They will look for the exacerbations. They will follow the patients for the emergency visits, cardiovascular, and if the patients require a hospitalization. Actually, this is a total number of COPD patients in the community, either is diagnosed or undiagnosed. and those patients who are diagnosed as a COPD, and those who will be followed in the artificial intelligence and machine learning to follow those patients. That we have to extend this 2 cycles until we cover the whole COPD patients. How can we screen those patients? There is a BOMA score validation, which is validated by up to 76%. And then we involve those patients and diagnose them. And then we are following those patients who are at high risk for a COPD. And the quality standards in the COPD patients, all based early detection of COPD patients at high risk of exacerbation and mortality, and the machine learning based prediction of the disease prognosis and qualifications of the future risk. There is a early intervention with a triple fixed dose combination for those patients who have a higher risk. And then we will go to a treatment recommendations and the KPI to follow this model and to examine the efficacy of this model. By 2024 milestone, we are provide the patient's identification. It's the guideline updated and adopted to Gold 24. And we have to redesign our pathway, and we have to do a world-class publications according to these kinds of models. This is a real model that is done in one of the GCC countries, and it's show that around 30,000 of patients, they are COPD patients. 11,000 of those patients have a high risk of COPD identified by the machine, and the accuracy of the machine learning was 86%. And those patients who are having a high risk, they have either the recurrent exacerbations or recurrent emergency visits, or they have a cardiovascular events, or they have more than one complication. So they adapt their guidelines and to the Goal 2024, and they start those patients to maximize those patients up to according to their classification. Which patients? They have 86% risk of developing future exacerbations and least optimization treatment, and those patients who have insurance under the government program. The actions that they take, they start to counseling those patients and managing review. They counseling of the disease complications, and they try to maximize the treatment. And the impact, they found that the early intervention with the triple fixed dose combination and leading to reduce of exacerbations and emergency visits and inpatient visits, and will lead to also the health resource optimization. What is the kind of publications that will be helped for us? That the publication plans, the opportunity for the artificial intelligence and machine learning is to drive a value-based health insurance outcomes for the asthma and COPD, and the impact of the analysis of the treatment optimizations. After the 6 months from optimizing the treatment, we will retain to see is this effect on our goals or not. Okay, we have, this is the last slide. The BOMA score is for proactive detection of COPD underdiagnosed. It is a questionnaire that in Arabic and English version, if the patients have, it's a symbol, proactive detection of COPD underdiagnosed, and a cutoff level of 5 or more score indicates the patient require a spirometry to confirm COPD. The BOMA score has shown 76% is in distinguishing between individuals with and without COPD. And if the patient is at risk for, we will look for those patients who are at risk for COPD, those who are 40 years or older, are current smoker or exposure to biomass smoke. and the high risk subjects, those who are get 5 or more, and they have to go to confirm the diagnosis of COPD by spirometry and meeting the definition of COPD. This Puma, they can deliver it through the paper version or through the electronic version. Thank you.
Dr. Asiri, for this interesting presentation. Any comments from the audience? Comments, concerns? تفضل دكتور.
Abdalla, thank you very much for your presentation and the use of AI in COPD, especially with the Puma score. As you know, COPD is a spirometry diagnosis. And COPD is a spirometry diagnosis.
Yes.
If we don't have PFTs, how can we diagnose it, even with a Puma? So we're still going to have the same thing with physician diagnosis of asthma, where we start inhalers and we treat with steroids when they come to the emergency department with no evidence of COPD in spirometry.
Yes.
So the question might not be necessarily to you, but where is the PFT?
Yes. According to the POMA score, that if the patients they are at risk and they are above, they have 5 points or more, they have to go for a confirmatory. Then you are detecting those patients as a COPD. You are confirming that they are a COPD. After that, the POMA score, it's used to screening tool. It is not using for a diagnosis. So after you find this patient is at risk or they have 5 points or more, you have to go for a spirometry. So any patient will enter to the artificial intelligence, they have to be confirmed as a COPD. And the good thing is that the machine learning, they will follow those patients and they will tell you this patient is at high risk for exacerbation and cardiovascular events, and those patients, they are not. And after you maximizing the treatment, you will follow these patients after the 6 months and see how effective your drug is. Is it effective or not? So it is an opportunity to give you a good publications, and it is a good screening tool to examine the prevalence of COPD that we are looking for. There is the Saudi COPD group. We are looking to do a huge study in the Saudi Arabia regarding the prevalence of COPD. And this project is still me and Prof. Lubain, Dr. Badr, they are looking to the questionnaires. Still we are want to launch because the prevalence of COPD, it is not quite established in Saudi Arabia. And as you see that in the presentation, the first slide in the presentation, there was a statement from the World Bank that the cost of COPD alone, comparison to the national chronic disease, is the second after the diabetes, and it is almost $7 billion per year. So this is a very huge medical problem that we are faced. We need to look for it. We need to have good numbers about those patients, and we have to act according to what facilities that we are able to perform or to introduce for those kinds of patients.
Thank you very much. Any further question or comments? Dr. Abdullah, do you think we would be able to pilot this in, let's say, one center of ours?
I will talk about the pilot. Yes,
Yeah.
it's. I think it is very important to start with launching such program for a COPD. Also, I think it will be helpful for us to look to those kinds of patients with increase the prevalence of smoking in Saudi Arabia by up to, I think, 30% of population, they are a smoker. Maybe Prof. Hamdan correcting me in this. I think it is 30 to 40% of our population, they are a smoker. And we know that the smoking inhalation is the strongest risk factor for a COPD. And I think also the COPD will be in the next 10 years a national problem in our community. So launching the program in one of our hospitals, it's a brilliant idea to see is it helpful for those kinds of patients, and we will see the impact on the healthcare facilities if we are following those patients and what is the result.